Are you guys okay with me beginning my presentation? Okay. All right, let me share my screen. And I don't think I will be able to see if you guys have any questions in the chat while I'm presenting. So if anyone has any questions or someone sees something in the chat, feel free to just come off mute and let me know so that I can appropriately answer that for you. Okay, so can everyone see my slide? Okay, perfect.
Yes.
Perfect. All right. So hi, everybody. As you guys all know, my name is Kim. I am the physical therapist trainee on ITT Team 1. I had the pleasure of evaluating Jonathan actually almost a month ago, or a little bit over a month ago, for our PT evaluation. And big shout out to Kelly Farrell and her mentor, Jamie, who assisted me with the assessment because my mentor was unable to come for personal reasons. So I appreciate you guys a lot taking extra time. So first off, we started off with the subjective interview. This subjective interview was a little bit different than our typical PT evaluation because I was able to observe Kelly's session the week prior, and the patient and mom, he had a lot of big difficulty with separating from mom at the beginning, and it was harder to talk with her with him there. So she asked if I could do this ahead of time or if we could just immediately separate them for my assessment so that we could potentially improve compliance for Jonathan. So I actually called the caregiver prior to this assessment to gain this information, which is a little bit different from what we typically do here in PT. The mother reported that, like we knew before, that Abby kind of touched on, that his right foot was turning out, that she had noticed this since he was around 1 year old, and that this worsened when he was tired or fatigued, and where it has even happened to be where he has had to be carried during when they go to Kings Island and when he gets tired. So to the point where he really needs a lot of assistance. Then mom also explained that he wore braces in 2020, but further stopped wearing them. She kind of just explained that he didn't really like them and that he wasn't really tolerating. She didn't give me too much information on what the braces were, other than that he had braces on both sides. The left one was shorter, that it just went into the shoe and kind of helped with what she called, individuals had reported, his weak ligaments in his left foot. So I'm assuming that this brace was what we call an SMO, a submalleolar orthosis. And then the right brace was one that went up his calf, which I would assume would maybe be some form of an ankle foot orthotic, which can help with something called drop foot, which I will be discussing in a later slide. And when he was complaining of this right foot and left pain, they did visit orthopedics in 2019, but he was cleared through orthopedics. They did not see anything abnormal. And mom said that he previously was given Tylenol for this pain management, and that although he used to complain of pain very often, that he didn't as often now. Mother also reported the following, that he trips frequently, usually a few times a day. And again, he did used to wear braces in 2020. These braces were provided by the early intervention physical therapist they saw up until he was age 3. He has not received any PT services since then. So this early intervention is only provided up until age 3. It's a government association, and that's why it was ended by 3. It wasn't because he didn't need PT services anymore necessarily. His mom does believe that he has learned to compensate with how he walks, and that maybe that could be why he doesn't complain of pain as much, but he does still trip. Furthermore, I wanted to ask them about his birth history. He was born at 39 weeks, so not born early, but his mother did note that they attempted to deliver vaginally, but he started to come out feet first. So instead of doing this, they completed a C-section. And she said that his right foot got stuck during the labor and delivery. And she wondered if that could have affected his ability to walk with the right foot. I'm honestly, as a PT, I'm not sure. I would have to know a little bit more about what occurred during that instance. He did not have any NICU stay. And this is all really important from a PT perspective because we want to make sure that there isn't any risk factors for something neurologically causing that right foot weakness or impairment in walking, such as cerebral palsy or some other diagnosis. But it doesn't seem like there was too much birth trauma involved with this case. We also reviewed his past medical history. As we've heard before, he has had PE tubes placed and a tonsillectomy. Overall, mom thought that he was pretty much on target for development. And again, he had the previous early intervention for physical therapy. So overall, this actually occurred during my session. When asked of pain during the session, the patient actually reported that his pee hurt at one point in the session while holding his private area. At this time, I offered if he wanted to go to the bathroom, he could, which he later declined. And he did not note of this pain during the remainder of the session, but I think that this is important to point out in case we need to look more into toileting concerns and if this is a recurring issue for him. Overall, for play and leisure, if any of you guys watched my video, loves being able to move things around. He loves doing somersaults. He's very good at them, even though it might make us kind of afraid. But per mom, he also loves going on his scooter. He loves spinning and he loves somersaulting. I will say though, even though he loved moving around and loved pushing things and loved picking things up, his body awareness and safety awareness was not the greatest. So he would often be somersaulting into things that maybe weren't the safest, or he was tripping over things as he was running around. So just that coordination component and that safety part wasn't exactly there. Furthermore, in his home environment, he lives with his mother, father, and sibling. He lives in a one-story home with no steps to get in. His mom said that he has a ramp to get in, and that his bedroom and bathroom are on the first floor. This is important to kind of remember in this aspect because we'll see later that he did show a little bit of an immature pattern on the steps. So in this case, it may be a lack of opportunity to use the stairs because he only lives in a one-story home. For education, his mom reported that he goes to Early Head Start through Gallatin County schools for 3 to 4 days per week, and then he's receiving speech therapy services. So he has an IEP, which is an individualized education program. So one of the biggest concerns for his physical therapy visit was looking at his way he walks. So I kind of alluded to this before, but there's something called drop foot in physical therapy where someone, as they are walking, you really need to be able to pick up your toes to be able to clear that foot when it is not on the ground. So you take a step, you want to clear that foot, and then take another step. I'm happy to demonstrate this later from myself walking, but I'm hoping that some of these pictures kind of help depict what that is. So it is sometimes a weakness in the front of the shin. That muscle is weak and then it's not able to pull the toes up. It can also be caused by tightness in the calf muscle, which is the muscle behind the shin bone here, causing you not to be able to bring your toes up. Or it can also occur during a neurologic defect. So there could be some form of something like cerebral palsy or another condition that could be causing that weakness or inability to clear that foot. So it was really important later on in my assessment to do a kind of a clearing test of the different neurologic measures. So this kiddo did present with that. He overall really lacked right foot clearance about 50 to 75% of the time, where he would typically increase the amount he was bringing his leg up, like how much he was bending his hip and knee to be able to clear that foot rather than actually bringing up his toes, which I think is a big part of why he might be tripping on things in addition to his decreased safety awareness. Overall, during his running pattern, he did trip around 25% of the time when watching the video back. He also used his left leg to push off more than his right leg. So it almost kind of looks like a gallop rather than that true running pattern where you're taking equal steps on either side. And for the stairs, he really did prefer to hold on to the handrail when he wasn't prompted not to. He was able to go up the steps with an alternating pattern. So that's the step over step pattern without holding onto the handrail when prompted. But even when going down the steps when prompted, he still had to hold onto the handrail. And he did something called a marking pattern, where he would have 2 feet on each step. So he would step down, bring the next foot to meet it, step down, bring the next foot to meet it, and so forth. And this pattern actually suggests right leg weakness because it's showing that he can't lead with his left foot and control that movement down while staying on his right. So overall, what I kind of saw during my assessment was that he did have a preference in using the left leg in all of his gross motor skills compared to that right, which kind of can suggest that maybe this right foot drop could be due to more of a strength imbalance rather than a tightness or a strength issue. So, and I apologize, I think my picture's over the words a little bit, but again, this might just be due to a strength imbalance between size, and that could be contributing to his falls and trips. He was otherwise able to push and lift very heavy objects for his size, in my opinion. He was also able to maintain a tall kneeling position, which is this picture here. But he had to do it after a couple attempts. I think it was a little bit more challenging for him, and at this age, it shouldn't have been. So based on that and some of the balance activities, I think he may have some issues with maintaining positions, which suggests decreased postural control overall. And to go into his balance, he was able to maintain standing and sitting postures without support. He was able to stand on his toes for 4 to 5 seconds with increased postural sway. That means that when he was standing, he wasn't really staying still. It was kind of really moving about rather than that static posture. And then standing on one leg, he was able to stand on the right leg for 1 to 2 seconds and 3 to 4 seconds on the left leg. So these times are definitely lower than what I would expect for his age. At this point, he probably should be able to hold 4 to 5 seconds when balancing on one leg. So especially that 1 to 2 seconds on the right leg is a little bit more concerning. Overall, for his gross motor and ball skills, he was able to jump and clear both feet when jumping off level ground. So that means that both feet actually came up off the ground. Sometimes kids, if they're having issues with jumping, they'll kind of leap forward with one foot and one foot will come off before the other. He did not do this. He was able to throw a ball overhand and underhand, but he did kind of lack that trunk rotation when he was throwing, which also kind of suggests some decreased postural control and decreased trunk control. He was able to catch a medium-sized ball with an immature pattern. For the immature pattern, it's mainly suggesting at this age he should really be able to catch a ball just using his hands. But whenever we attempted this, he would more trap it towards his chest. So this was immature for his age. And then for kicking a medium-sized ball, he was able to mainly kick it with the right foot. And he was able to kick with either foot when prompted, but he definitely preferred kicking with the right in order to balance on his left side. Again, another aspect that may suggest an imbalance of strength between the left and right sides. So I did have his mom complete the Little Developmental Coordination Questionnaire. So this is a screener for children under 4 years old that can assess for monitoring for DCD. If you guys remember from Patty Sharp and Aaron Iverson, that is a condition that is in 6% of children that affects their ability to coordinate their movements within their day-to-day skills. So at this point, we wouldn't be diagnosing him with DCD, but having a positive score on this would identify them as someone at risk and someone we need to monitor for this condition. So based on his score, he got a 57 out of 75. which indicates a probable suspect for DCD. So this kiddo, we kind of need to continue watching. And as he gets older, it would be likely that we would want to do some more coordination tests and see if DCD might be an appropriate diagnosis for him. So then for our other observations for the lower extremity assessment, and I'll kind of go into a little bit more detail about this assessment as a whole in the behavioral section of this presentation, but I first just want to kind of highlight some of the numbers. So one thing I really wanted to make sure to assess was his ankles when he, since he was kind of turning his right foot out and having some issues with picking up those toes to clear the foot. I wanted to make sure to screen for any neurologic cause, such as cerebral palsy, that could be causing this asymmetry between sides. So one way that we do this is we assess for something called clonus. Kelly and I will be going over this a little bit more in detail on Thursday in our cerebral palsy PowerPoint, but in PT, we do quick movements to see if there's any resistance or any involuntary movements, and that can be a sign that there could be something wrong with the brain or spinal cord. So I did do this with him and did not find any of that on the right or left side. He also had full range with both ankle dorsiflexion, so that is the movement of the toes coming up towards the shin. So that shows that it's probably not a calf tightness, that he's not picking those toes up when he's walking. And then I also did something called a thigh foot angle assessment. So that is looking at how much the shin bone, which is the tibia, may be twisting either in or out for each side. So he demonstrated 10 degrees of internal tibial torsion. So that means that his tibias likely turn in, like they twist more towards his belly button than out towards his ears, which I found very interesting because based on how his mom's reports and my observations, he should have had something where his foot was actually more pointed outwards. So this finding was surprising to me, but I will give the caveat that he did not tolerate passive assessment very well, and he may have been fighting me. And I think that some of these tests may need to be recompleted just to ensure correctness. Then overall at his hips, so I looked at generally at his hip rotation. So when we are considering rotation at the hip, we consider external or lateral rotation, if you see in this picture, as the movement of moving the toes out, so out towards your ears. And then internal rotation, or we also coined the term medial rotation, as the toes coming in, so towards your belly button. So overall, with both legs, he had increased external rotation passively with the way I was moving him, where that would be the movement of his toes moving out. This measure was much more in line of what I was seeing clinically, since he kind of walked with his feet more turned out than more of an in-toeing posture. And because of his decreased tolerance to handling at that point, it was more measured through just general observation, kind of getting that gross measurement rather than a numerical value. Furthermore, we did also see some increased pronation. So that is the medical term for ankles kind of falling in towards the belly button on both sides. So this can sometimes suggest that we have some weaker muscles in the feet, and it can even mean weakness throughout the whole legs that can kind of travel down to the feet. Overall, I did see more pronation actually on that left side. So I can see why his mother was told that he may have weak ligaments on the left side, because there was increased pronation in this foot compared to this foot. And then I also wanted to look into what his leg length was. So I was able to measure his leg length from something called the greater trochanter, which is a part of the thigh bone that kind of sticks out to the side. And I was able to measure that from that point to the ground with his shoes on. This was important to look into because another reason why sometimes people can't clear their foot when they're walking is that the leg that is not clearing is longer than the other one. So just functionally, they're not able to clear that foot because it's longer than the other. But it came out symmetric as well. So overall, some of his impairments really involved that there is a potential decreased strength of the right leg compared to the left that I was able to observe through functional movements and how he preferred to complete various gross motor skills. As I will go over in the next slide, his decreased tolerance to handling overall. He likely has decreased postural control and balance for his age based on what I was able to observe. He also was tripping frequently throughout the session and just had decreased safety awareness for everything around him. He did have an immature pattern when navigating the stairs. He also had decreased coordination and motor control. But I also want to highlight his strengths. He really loves to move. That was definitely not an issue of the session. He loves to move. He loves to be active. He is able to lift and push very heavy objects, which takes a lot of strength. And I think that, as Kelly kind of suggested in her presentation, that has shown to his ability to improve his mood and just ability to regulate himself. And I think family is really motivated to help. They are very willing to retry braces if needed. And I think that the fact that we already have family on board and wanting to improve, I think will be a really wonderful thing in his case. So in his observed behaviors, so I originally had planned on completing the Peabody assessment, which I was able to complete with the other ITT team. And I was unable to complete the full gross motor assessment because with time, there was kind of some decreased attention and preferred for self-directed task rather than examiner-directed task. So in some cases, when we do not feel like we are going to complete the entire assessment accurately and in a standardized way, we are able to kind of measure these functional assessments through observations and gross motor skills, which I explained in previous slides. I will say he did have a better transition from his caregiver compared to the previous OT session. Perhaps maybe because we had things up that he already liked, like the swing and the Cloud9 pillow, and that he was able to move right off the bat may have helped. He did, again, want to constantly move and often was crashing to the ground. It was hard for him to kind of slow down and stay in one spot, which also could suggest some maybe decreased postural control. And he also had a very heightened response to the passive lower extremity assessment. So how I was able to handle his legs. We first ended up bringing mom in to see if it would be okay if she would move his legs. But it was very heightened compared to what I would feel like I typically see with kiddos. He did not really want us to do anything with his legs. And because of that, I would suggest the next treating therapist to recomplete some of these tests because some of the tests may not be as accurate because I don't know if he was able to fully relax so I could fully see what movement he had at his joints. And later on throughout the session, about the second half, he did become verbally and physically aggressive towards the providers after he became frustrated about not being able to continue swinging on the swing in the way that he desired. So that did show some limitations with my evaluation as well. And I did want to reflect on the assessment because as I know I am a new provider and this is an area that I am continuing to grow in. Following the session, I thought of ways I could maybe do this again to better control these challenging behaviors and improve patient compliance with completing the interventions. So in the future, I would have removed some of the distracting equipment because even though the slide and the swing, I think was very motivating to him, maybe providing less time on them so that we could do more of my therapy directed tasks, having a waiting chair, using a visual schedule, using visual aids, including positive choices such, Jen has kind of brought this up before, giving choices such as like, do you want to walk on the stairs next or do you want to jump next? So they still have that control and they can choose an activity, but it's two activities that I would like them to complete. And I want to say that I actually was able to use these strategies in the next LEND ITT evaluation the following week, and they worked really well. So I'm happy to have this as a learning experience and continue to grow in this area. So overall, my PT recommendations is that I would like to see him go to PT once a month for 4 months to improve the strength of the right side and his overall coordination. So I think that there is a chance that we could strengthen the right leg and improve his coordination as a whole, and maybe not need new orthotics on that right foot. I think that the best idea would be to complete a strengthening program. And if that does not work, the treating physical therapist can continue to monitor if we still need orthotics, and if so, what type of orthotics may be beneficial. I also think it would be beneficial for the family to first address the behavior concerns so that he can fully participate in PT services and reach his highest potential. Furthermore, sometimes in physical therapy, when we're not able to fully complete some of the assessments we want to see during the initial evaluation, we provide a list of things to be assessed for the next physical therapist. I did complete this in my notes. I noted some of the specific hip assessments, strength assessments, and posture assessments I would like to see in further visits to assist them in kind of helping them further evaluate the child and further determine maybe what is causing that gait impairment. Some of the interventions that I would likely include would be different interventions to help improve his balance, his postural control, and include task-specific training. So that means that, for instance, he had some trouble going down the stairs in a mature way. We would repeatedly practice going down the stairs with doing puzzles or something along those lines. We also will work on functional strengthening and stretching for any muscles that may be tight or weak, and also always including the parent caregiver education training to empower the family and make sure that they can help implement this at home. I did email a HEP, is the Home Exercise Program acronym that we use in PT. We did email an HEP to the family to allow them to improve general strength and complete specific exercises up until when they can initiate therapy. So I really wanted to make sure they had that at hand so that they could start working on things, since it would be so long between my evaluation and the ISS meeting. What questions do you guys have?
Nice job, Kim. That was so thorough.
Thanks.
How often are you recommending the stretches, whatever you put in the home exercise plan? Are you thinking like daily for them, or?
So ideally, something like daily would be beneficial for his muscles. I believe for a strengthening change, it's at least 4 to 5 times a week. But I actually recommended 3 to 4 times a week for the family. I think that they're very, they have a lot of things and a lot of information that they're being given, and I don't want to overwhelm them. So I usually recommend 3 to 4 times a week. If they're able to do more, I think that would be fantastic. But I also wanted to understand that they also have other kids at home and they may have other things going on, so I don't want to overwhelm them.
Thanks, Kim. That was a great presentation.
Thanks, Abby.
Kim, I thought that was a fantastic presentation. I really learned a lot and loved all the visuals. It was so helpful. How often, we always worry about when we see asymmetry like that, and I think we agreed that we didn't notice any tone differences or other like neurological findings, but at the same time, I appreciate that you added like considering other possibilities in future, having that assessed. I would imagine it's unlikely to see just DCD with an asymmetric exam like that. I mean, how often with kids that you guys see or follow a DCD do you have that kind of asymmetry?
I don't know in terms of, oh, sorry. I'm not sure, and maybe I'll have to tag Sally in on this, but I don't know the specifics in the research for asymmetry in DCD. I think that it's very possible that he could have a DCD diagnosis based on that he's also having impairments in his fine motor skills and motor planning. Usually tripping often is a common report from parents, but I would say that they could also just be more of a comorbidity, like co-occurring diagnoses, like the weakness and the DCD itself. So I've even thought about the fact that sometimes we have strength asymmetries just because the way we learned how to do certain motor skills maybe he just started to pull to stand with his left leg forward, or he only started doing the steps with his left leg forward. Or I know we haven't had discussions about this in Lend, but there's something called torticollis, where a child has tightness on one side of the neck, and that can sometimes lead to gross motor asymmetries between sides. So there's a potential that he maybe had unresolved torticollis, and that related into this motor asymmetry. That's why I thought it was just really important to try strengthening on the right side and see if that improves. And if that improves the ability to kind of keep his toes up, and or if we use an orthotic and he's able to keep his toes up better in that way, and we're still seeing the tripping and balance coordination deficits, then I think we would also consider a DCD diagnosis. So I hope that answers your question. I think that they can occur together, and they can also be separate conditions as well. And Sally, feel free to jump in if you think of anything else.
Yeah, I think you guys are making all the right points. One is the big thing with asymmetry is to check for abnormal muscle tone, and that didn't seem to be, and or birth history or other history that would be indicative of something neurologic. It's not uncommon for kids, just like Kim said, to have this strength asymmetry that then becomes a movement asymmetry because they have a stronger limb going up versus coming down the stairs. Even that postural asymmetry in his ankle foot is not super uncommon. So yeah, I think the strengthening piece, and I also do wonder, I did not see him in person, but watched the video. I do wonder if some of his tripping and falling is due to him not slowing down enough and just sort of barreling through the environment, right?
Yes.
Body awareness. So there's definitely some biomechanical factors here, but there's also some sensory behavioral pieces. And I really like what you said about he could benefit from PT, but there's probably some other things that need to happen first in order for him to maximize his gains from that participation. But I thought you did a really nice job. And I think many of your fellow trainees have identified that sharing the reflection you did on that, experience really helped them, in understanding that process. And so thank you for doing that.
Thanks, Sally. Appreciate it. Does anyone else have any questions?
Okay, if nobody has any questions for Kim, good job, Kim. Kelly had something she wanted to share right after Kim went, and then Kate has just a little bit to add after that. So Kelly, it's all yours.
Great. Okay, I will make this a little shorter based on time, but I also did some reflecting with Kim after both of our evaluations. And with my time spent at TIP, which is a therapeutic interagency program with kids with trauma and abuse, and typically they're in foster care, and he really just reminded me of one of my like a lot of the kiddos I see there. And I wanted to kind of bring it to the team of possibly discussing a trauma diagnosis to provide correct treatment. Kim kind of highlighted as well. I don't know if OT would be appropriate before really addressing his behaviors and making sure therapy is appropriate for him, and just really highlighting if this isn't identified, it could do more harm than good. I don't know if anyone watched the PT evaluation, but he did not want hands on him. And as a treating therapist, I feel like it's extremely important to know before going in to be mindful of that and kind of creating a safe space. I know for OTPT, we do fit treatment, and those are families that might come in once a week, but seeing a different provider. And I don't know if that would be appropriate for him just based off the inconsistencies we saw. So just kind of looking at that and making sure we're providing the correct diagnosis and correct treatment. Just some of the things that we saw, the separation, him stating my P hurts. Looking back, I would have kind of wished we'd be like, can you show us where it hurts? Because we don't truly understand that. The emotional reactions that he faced when Kim went to touch his foot, we had to kind of step away and be like, our hands are here, we're all in front of you, and really show that he was safe to help him calm down. His regressions and ADLs, the restless sleep, the public urination, and just limited information about the sleeping arrangements at home, it just kind of reminded me of some of that. And I wanted to bring it to the team and see what everyone is thinking, just to make sure we're providing the best treatment possible.
Just to add to that real quick, Kelly, I remember when we did the parent interview with mom. Mom says whenever she takes him to school, he will scream and not let go of her. That they have to physically take him away from mom.
I think it's a good thought, Kelly. I think in what I saw when I like evaluated him was a lot of separation anxiety, like falling more under, I mean, we know like trauma often falls under the umbrella of kind of anxiety disorders too. And so what I was seeing was his expression, maybe related to his trauma experience, was separation anxiety in my visit, at least, which it was difficult to tell. It's becoming abundantly more clear at my assessment. I was like, this is one of the first times I had heard of him having quite severe separation anxiety, like I was seeing in the room. And then you guys saw something similar too. And that wasn't reproduced in every single setting. Like he did separate better with other. And so I attributed it to kind of like the lack of rapport that I had with him at the time. But I mean, it does seem like maybe in a couple of different settings, he is expressing maybe a little bit of separation anxiety. But it's difficult. Usually you have to see that kind of consistently in multiple settings. And that would probably like the kind of an unspecified anxiety, honestly, unspecified anxiety is really probably where I would go rather than something more trauma specific, but that's just me. But I do think trauma informs that, right? Like that is the whole background behind that expression of anxiety. But I would love to hear kind of what psychology thinks too.
Yeah, I'm glad that you brought that up, Kelly, because I think throughout there's a lot more of both symptoms and like understanding of his social context that feels a lot more like trauma or ACEs or something in that ballpark. So I was kind of going back through my notes and I'm wondering if like an adjustment disorder, and Abby, I don't know like how that goes together with the way like you approach and are thinking about it, and like with anxiety unspecified. Adjustment disorder we usually use when there's either some kind of event or events that have been really stressful. So you're kind of seeing signs of trauma either through emotions or behaviors. And you can specify an adjustment disorder with conduct or emotion problems or both, which I think he kind of has, that I was initially seeing as like, oh, yep, that's ADHD and seeing that. But I'd be curious, and Lindsay, I'd be curious if what you think, if it looks more like that to you too, with some of the more information that we have.
I was actually just going through your report too, Kate, and it seems like he had a really good visit with us. So we didn't see a lot of those symptoms during our visit. And then when we asked about mood and symptoms of anxiety, Mom didn't endorse any. So that wasn't on our radar back when we saw him in January. I think the other thing that happened back in January is we didn't have that history of those psychosocial stressors that was omitted from the diagnostic interview and learned later. So we have more information now. We can kind of flex and update things to capture some of those other anxious symptoms. But if this were me in real life, that would be a discussion that I would have in the ISS to get, ask more follow-up questions and get more clarification. So we are making an accurate diagnosis with all the information that we have. I don't know if I answered a question or just made it more confusing.
I find it super helpful. I learned a lot based off what you guys just said. I don't diagnose or anything like that. I just didn't want him to fall through the cracks. So thank you.
I just have one. Oh, sorry, Abby.
No, please go ahead.
I just have one quick follow-up question as a learning opportunity from all of you. When he specifically said, like, what kind of occurred was he said something was hurting. Kelly asked him what was hurting, and then I stepped in, and he said twice, like, my pee hurts, while holding his private area. And I asked him about going to the bathroom, and he ended up saying no. Is there, based on, especially from Abby, like, is there things that we should follow up with asking mom about this? Is there a better way I could have approached that situation? Maybe it's nothing, but I want to make sure that I'm bringing it up if it is something and it needs to be addressed.
Yeah, and I think just clarifying for me, Kim, I guess, what is your concern? Like, it's okay to just say it, I think, in the group, but what are you concerned about when he says that?
I would just want to make sure there's no like history of abuse or anything with the limited information we have. Personally, I don't know. That is not an area of my expertise at all, but I don't normally have my kids complain of pain in that area. And I wanted to make sure that there wasn't something I was personally missing, or if there was something missing that we needed to address through bowel and bladder that we hadn't heard of yet. So I just wanted to, I may be completely wrong. This is not my area of expertise, but I wanted to bring it up.
And I will say, we always have to think about that, right? Like, I think it's always appropriate when young kids are touching their privates, or, you know what I mean? When you hear things like that, it's always appropriate to kind of like we have to have kind of a low threshold for asking more about that. So I definitely don't think it's inappropriate to consider that in any setting. I think, but I think from my standpoint, and I mean, Marta's going to be my resident expert too on this, but like what you would look for if you really had a concern for like something inappropriate in terms of trauma or like sexual abuse or anything like that, then you would want to know a little bit more about their toileting, but you would also want to know about any like sexualized behavior. So anything like, we have kids that try and touch other people's privates. That's not always evidence of like sexual abuse, but it's something to consider. We have kids that are kind of overly sexualized in how they describe their parts, and how they do their drawings, things like that. I think it's always appropriate from your standpoint as the therapist to reach out to the pediatrician, social work, whoever, and just say, when you're seeing kind of repeated instances, I think if it's one time where they're kind of like holding that area, we do see UTIs in boys. And we also see kind of other things too, when kids get dehydrated and it burns when they pee because it's concentrated. So there are other causes beyond sexual abuse that we have to consider when kids are complaining of pressure or something else in that area. So then you can always be like, do you have to go to the bathroom, and like ask a few times. But if you're seeing kind of repeated instances of them like touching their privates, or, like kids will masturbate, and that can be a normal childhood behavior. So not necessarily that, but asking the parents, do they have a history of kind of touching down there? Have you heard of any concerns where they're seeming to have a lot of distress around like bathing, around bathroom times? And that's kind of treating it more non-specifically before we narrow down, I think, is probably the best way. And then if you're ever uncomfortable, or you're like, this is beyond my scope, talking to their pediatrician, I think, would be the next thing I would do as the therapist. But yeah, we see a lot of different reasons why kids do that, and we always have to consider that. And I think you guys always have to consider that too, because that helps us. So I hope that answers your question. I'm not concerned for him here, but I think with his history of trauma, we always have to keep like a broad differential, right? That's what we always say.
Yeah, thank you. That was so helpful and very educational for me. So I appreciate that, Abby.
I would also say we know from school that he has some times of urine holding and sometimes of purposefully urinating in disruptive places and situations. So that might be leading to some of the pain as well. So even just asking mom, like, is this normal? Did he have any concerns on the way here? They did drive far. So if it's early, like even just suggesting, he may say he doesn't need to go, but you guys want to go ahead and try, so that once we get started, hopefully you won't have to use the bathroom during that time. Things like that. Shannon can't be here today because she's at DPS. So since our visit, since we've last seen them, Shannon had a very difficult conversation with mom at the beginning of last week when you guys came back from spring break. And actually, Abby, Kate, and the faculty team of us met to talk and problem solve through this. If you say the word trauma to mom at the ISS, I would be very, very gentle. Mom read everything all of you wrote in my chart. She already has an opinion about what you're thinking of her and her child walking into the visit next week. She did agree initially, she wasn't going to come to the ISS. She was done. She did agree to still come to the ISS to hear us explain our reports and what we are sharing and recommending. She told Shannon some of the information she received from school was completely inaccurate. So we did gather what mom reported as what was accurate and actually addended some of Shannon's notes. Mom denies that there was ever a protection order against father. She also reports that what we're referring to as trauma happened when he was a month old. And this has been done and resolved for years. It's not current. Mom denies any current concerns with father. She did say there was a period of time when Jonathan was a month old. There was an incident between mom and dad. Mom and dad were both court ordered into parenting classes. So what we talked, like part of this was she read PCIT and counseling and those kinds of things and thought we were sending her back to parenting classes. And she is going to stand by dad also. Whether or not we meet dad, we still are unsure, but still thinking it's unlikely that we meet dad next week. But she does not agree with all of the assessment about the impact of dad that the school is reporting, because most of that's not in any of our documentation. That's more of the reports from school. So she was very frustrated, maybe is the word we can use. But in the same token, she's still coming and she is still allowing us to send the Zoom link to the school so that the behavior specialist and the director of the Head Start program both are attending the ISS on Zoom. So she still is fine with that plan.
I was not part of the conversation, but part of the discussion about the conversation. I just want to give big, huge kudos to Shannon and the work she did on that phone call. It was definitely a crucial conversation, a challenging moment, and to Marta for her excellent guidance and mentorship during that phone call. The fact that mom was so angry and upset with what she was perceiving as our recommendations and how we were labeling the situation, to move towards coming to the ISS, being ready to engage and inviting the school to be part of it is a huge leap. I think one thing too, Marta, you may have said this, but you mentioned during our conversation that mom read things in the reports that said mom reported X, mom reported Y, which is really how we document. And she read that as we didn't believe those were things that were happening. And it's weird to be on the other side of this as a patient and family. I have heard some of you all say things like mom endorsed. Psychology does that. It's such a great term. And I'd never heard that before. We were taught to write mom reported, mom said, whatever. So just going into the ISS, we've had a meeting with Abby and of course Shannon and the group that will be in the ISS to really talk about with Kate, what are the boundaries of this conversation? And it sounds like, really treading lightly, but also keeping these things in the back of our mind, asking more questions, getting more information about the things you're bringing up, Kim and Kelly. But also just considering what else might be added to that differential diagnosis. And just like in PT and OT, we don't just assess once and are done. We are constantly reassessing, as will a provider who is a physician or a psychologist be reassessing the situation and connecting dots as they go along in that therapeutic relationship. But thanks for bringing all those things to the forefront.
Marta, I have a quick question about that discussion with mom. I'm curious, just to make sure I understand. So I believe the school had reported pretty significant behavioral and developmental concerns. But mom disagrees with that.
No, she agrees with their reports. So Shannon had even, like, we had been really delicate and not documented everything school reported to us per their history. But there was one line, and what Shannon probably has 6 decently long phone calls, and mom caught the one line and one that said there, and she didn't call it a temporary protection order. It was some other term that the school gave her, an odd term. It wasn't a term we usually would hear. Mom caught it. And so mom's like, that is not true. There was never a protection order. Which there probably was, because mom said when he was a month old, there was a period of time Dale was not allowed to have unsupervised contact with him, and he only had visits at the Family Nurturing Center in Florence. Typically, that means there's some sort of court process happening. You can't, like, Children's Services can't tell a parent you can't see your kid. That has to come from a magistrate. So something happened. There was a court appearance, but what they termed it did not match up in mom's head to the same way that the school had termed it. And that was one of the many things that she was upset with. When it came to school, it was just the history of the domestic violence and how they worded things that mom wasn't in agreement with, and wanted to clarify that we're not talking about something 6 months ago. This was all when he was a baby and he was an infant. So I also think maybe in mom's head, and if you know trauma, mom might be thinking, well, he doesn't remember that. But we know that if there's a removal from your parents, or there's this happening in your home in a month, you may not remember the trauma, but it still impacts you. Mom may not have that kind of same knowledge, but her point also to us was, this wasn't last year even. He was a baby. We have dealt with it. We have resolved it. We did our due. We did what the courts told us to do in the cabinet. Children's Services was open. She did say, yes, I had a cabinet worker. I worked all my case plan. He is back with us. No cabinet opening. She was fine with, like, school said these behaviors. She agreed with what school said about behavior. She disagreed with how frequently school says he comes. She says he goes to school more often than school reports him attending school. That makes sense. So that was the, like, school disagreements. And the other pieces were what Sally was saying. We write everything. Mom reports this behavior, and she didn't feel like we were saying, and we saw it too. She felt like it was, she's saying these things and that we're not saying we see them too. And she did not come out and say this, but it really felt like we were saying, she read those as, this is a parenting problem. And she wants us to know this is more than parenting. There's something else going on with him. I think she got the idea we're not giving him an autism diagnosis based off of our diagnoses that are already in the chart. And she was thinking he would get an autism diagnosis, and that would help understand his development and his behavior. So that also, I mean, Shannon didn't say the diagnosis. She's like, I don't know what the diagnoses are. I'm like, well, sort of. We can't talk about diagnostics, but the team will talk about that and why they came to the diagnosis they came to.
Thank you. That's very helpful. Because I'm like Donna, I'm kind of reflecting back on the discussion that we had with mom and what she did share and what she didn't share and what we felt we knew, and how her perspective on how she shared information, because I think this really comes back to perspective, her perspective on the information versus maybe the school's perspective on the information. And then it sounds like mom worried possibly or upset that there's been a judgment maybe already, that we're using the word reported when we're really using the word reported to try to remain neutral.
Right.
But she's reading that as a judgment.
Yes.
That she said it, but it's not believed in some way. So that's really helpful to understand.
She straight said, this isn't just a parenting problem.
Okay. Okay. That's interesting. Again, just kind of based on some of the discussions Donna and I had, mom was kind of back and forth. And yeah, we were just trying to figure out kind of what her understanding was, and that belief system. you know, that worry. She shared with us what I felt was some worry of, could this be a parenting problem? So that's obviously something that's really concerning her right now, is that we all remain as neutral as possible. So I appreciate you sharing that.
On the other hand, even during that meeting, she did say they've been coming to Children's for a while now. So I think it was, we saw him talk to mom during the OT eval, and she said that he's becoming more comfortable. So he's starting to act like he is. And so maybe he's feeling more comfortable. So now he's giving more information during the OT and the PT eval than maybe he felt comfortable doing before with Abby or with Kate. So now he's giving more information.
I just noticed Kim's comment in the chat about the word reported. So I've read a lot of children's services reports, at least in my county, and the word reported is used a lot in children's services. And so understanding that this family has been involved at some level, at some point in time with children's services, that could, just the word reported can bring up that can bring that situation back, that reports and filings and paperwork from children's services, the word reported is used a lot. So that's really interesting. You know, just something to kind of realize, Kim, is that this parent she's already carrying something over just the simple use of that one word. So thinking through, like how you did earlier, like I kind of thought through, how else could I do this? How could I do this next time? What word can we use possibly? You know, sometimes when we're making notes that remains neutral, that communicates in our notes what a parent has said to us, but a word that feels even more neutral than reported.
An excellent
Children's
point.
services and social work always write report it
Yeah.
until
Right.
a
Mom
court
said-
finds it true.
Yes,
Right.
until it is noted as substantiated, right, Marta?
Yes, until that point, everything is reported.
Right. In our notes, we could write mom said, mom stated, you know, yeah, great discussion. Well beyond where we thought this was going, right, guys? But really,
Before we move on, Kate, did you have something else you needed to share?
Yeah, it's really brief. I just didn't have the teacher report forms when I shared out for psychology, and I have them now. I can share my screen really briefly, but basically the teacher report, so this was of the BASC, which is just behaviors and emotions and how he's doing with those. Teachers' reports were pretty high on everything, and actually the form has an index that controls for like over-reporting, and it was flagged for like this is an overly negative kind of view, or we're getting a lot of high ratings that we wouldn't necessarily expect. So we wrote that in the report, and we'll be clear about that. That being said, it was mostly consistent with moms, where teacher was reporting some externalizing problems. So with aggression, hyperactivity, was rating higher on internalizing, flagged for symptoms of depression and withdrawal. And usually with kids, depression looks like irritability, kind of grumpiness. So that makes sense based on some of the moodiness that we've talked about. So just overall kind of high scores there. And then similar to mom, was seeing adaptive skills or like daily living skills, self-care, flexibility, lower than we'd expect for someone his age. And then the teacher also filled out the brief, which, just as a quick reminder, is a measure of executive functioning, or how you're able to self-regulate, flex to different situations, kind of use your inhibition and slow down, not act impulsively. And so teacher scores here were also flagged for overly endorsing symptoms, so really high profile but again, was really consistent. And on this, anything above a 65 is considered clinically significant. So similar to mom, parents saw a lot of difficulty with executive functioning. So just wanted to share that out there. And I think goes along with what we've been saying, where there's a lot of clear need and mom and school are on the same page, but school is definitely emphasizing the problem. And we, at least I feel like in teacher forums that I send out, that we do get high ratings a lot because they're just really wanting, I think, us to know, hey, there's something going on and this kid needs some support. So just wanted to share that. And then I can move to sharing the notes if there are no questions about that, or if that's what we're ready for.
Yeah, I think that's good.
Okay. And so am I talking through this too? Which I totally can if I'm sharing.
Do you want me to talk through it since I'm doing the ISS?
That'd be great.
Would that make more sense?
Yep.
Okay. So
And Abby, I think too, like instead of running through the whole PACE content sheet, we can kind of use the time more to kind of plan,
yes,
you know, what our recommendations are going to be and try and prioritize them as best as we can.
yeah. So
I
I'm
totally agree with that.
okay. I'm
I like
here.
the bottom of that form.
What'd you say, Sally?
The bottom of that form has like the recommendations and the diagnostic impressions.
Yeah, I think when we scroll through, we'll see recommendations for each section. So I'm kind of like, since I'm leading the ISS, I'm your MC for the event. Not probably how I'll phrase it for in the actual ISS, but so what I don't know who's going to be there. Maybe we should start with that. Obviously, I will be there, and I think psychology also is planning to be there. Who else can be there? Start generally with that.
I can be there if needed.
Okay.
I think I can also be there if needed.
Okay. And we can run through and see if we think you guys need to be there or not when we go through the recommendations. But I usually just start my ISSs. I don't want to open a can of worms with this mom by, kind of letting her vent too much in the beginning. So I do kind of want to help navigate this along so that she can get all the information from us. But I will probably just ask how things have been going since the last time we saw her, updates from school, updates from home, anything she wanted us to know that has happened in the meantime. Sometimes I will ask, how they felt the evaluations went, but I think we've gotten some feedback already on that. So moving forward, I guess I can just go down the list of our, so yeah, if you scroll down, I think technically medical is on here first. So that's me. And I probably will let some other people share and then we can loop back to me at the end. But so I guess we'll start with hearing audiology. It looks like we had some normal hearing, but anything from audiology standpoint that you want to make sure that we say in ISS?
His auditory system, he'd had the history of PE tubes, which have since extruded, and it sounds like he has not had troubles with ear infections since that set of PE tubes. So as long as they don't continue to express any concerns about hearing or ear infections in the future, I would say that audiologically we don't have any concerns. So hearing, we already shared that with mom at the visit, that hearing was normal, and that unless she has future concerns, he would not need further follow-up with audiology.
Perfect. So that sounds good. In terms of genetics, I know that we've gone through quite a bit, but from a genetic standpoint, I see your recommendations on there, but anything you'd like to add?
No, I'm not concerned for anything in particular right now.
Okay. Yep, and we're not recommending any further genetic testing. So And I know I heard Courtney, I was obviously there with you in the visit, so I heard you kind of explain all of these things to the mom too. So we'll just kind of briefly touch on that and move forward. I think the next part is psychology. I might have psychology go a little bit later, right before me. If that's okay with you, Kate, because I think that's kind of going to be the bulk of what we're sharing. So I'm going to loop back to you guys. Maybe we can do speech next. Anything from speech? I know we're recommending speech and language therapy. It's difficult because they live far away.
Yeah, and I think he's already receiving speech at Head Start. So I would recommend just continuing with that, as well as maybe a focus in emotional regulation, some sort of behavioral component to that as well.
Okay. Okay. So we're thinking that they can maybe do some of that in the school too. Are you thinking, Maria? Yeah.
Yeah, like carry over from Head Start into whatever program he eventually goes into, given that he does have language delays below the average range. So.
Okay.
Mhm.
And we can see if they have, right? I don't know how, I know some of their therapies are difficult in their area. I'm not sure about speech in their area.
I wonder if, since school will be there, if we can ask about like homeschool communication with speech so they can practice some of the things that they're doing in speech therapy at school at home. Because that's kind of like the big benefit of private speech.
Yeah.
So if they're not able to do that, if we could maybe have a discussion and encourage more homeschool community. I don't know if they're already doing it, so I don't want to assume they're not, but it's something to bring up since they'll be there.
Yeah. Okay. So home options for speech or activities that they can do, something that the parents can really like more parent guided, I guess, for the home. So I can ask the school that at the meeting. That is very helpful. And then I guess our next one is we're going to hit OT next.
Yeah, so I did recommend therapy with mom. I gave her the folder and I know she was interested in the Kentucky location. And we did say once a week for 12 to 6 visits to kind of get started. However, the more we kind of observed and saw, I think it would be pending his behaviors. A lot of times we see challenging behaviors get in the way of goals. So I don't know if like behavioral therapy or kind of psychology should be the front runner of recommendations and then following OT and PT, or if we could get OT services at school. I don't know if the school would be open to that, is what I'm thinking. Jamie, I don't know if you have any other thoughts.
No, I think that sounds good. Yeah, I think it would be nice for them to get outpatient OT, possibly after some behavioral therapy, if possible, just because I think some of mom's concerns were more outpatient OT focused as opposed to school focused.
Okay.
Just to throw like another curveball in, he is rounding out his time at his current Head Start location, who was also his early Head Start location, so have known him since he was a baby. And next year he has to go to the public school and enter kindergarten. And the Head Start program has already expressed concern that the level of support they're giving mom and the amount of services they're giving to him will not be deemed as necessary when he goes to kindergarten next year. And Florence is like the closest thing I've got for anything to them. So going to Florence, and they go to their pediatricians in Florence. So I think mom's pretty aware that they have to go to Florence for anything. So like anything we're recommending, we're telling them basically to drive to Florence for it.
Okay. Okay. And that's a good point, Kelly, that you bring up too about we're gonna, for both OT and PT, we're gonna be talking about behavior and recommending that. So I'm making an executive decision just to flip and put psychology in front of PT and OT, since we're making that recommendation based on behavior. thanks for sticking with me through this trialing time for me. But yeah, so I think we'll put psychology in front so that it just makes that conversation flow a little bit better for both physical and occupational therapy. And then I can round us out at the very end, because I'm sure then that will there may be some feedback at that point for me. So psychology, before we move on to PT, let's pretend psychology is going ahead of of occupational therapy, but thank you, Kelly.
Okay. So do you want me to go through like the test results with them and kind of walk through the report at that time too, leading to the recommendations?
Yes, that's
Okay,
what I
cool.
was thinking, as long as that sounds good to you.
Yep, that sounds good. Just wanted to be clear. So I will do that. And then, yeah, our biggest recommendation is some kind of behavioral therapy. And I'll work to frame this, it's not framing, this is what it is. With kids his age, the therapy has to include the caregiver, because we can't just work with a kid 1 hour a week and expect, especially a 4-year-old, to be able to, take all of that or be motivated to and make changes in his life. So we're really coaching the parents to be his therapist. So I'll talk about that and talk about some of the benefits of PCIT and how it works a little bit, and just talk about it's a little bit different. It's fun. You'll play together and kind of have a bug in your ear, and just learn some strategies for keeping play fun with him. So we'll talk about that, and then with the PCIT, that is ideal. We know that there's not a lot of providers providing it close to where they are. So if PCIT is not available, another type of behavioral therapy that involves the family will be good for them. And we have a couple of specific places to refer them to. And then just encouraging them to share the report with school, in his next school that he's at, in case there are any updated supports that he needs. And then talking with pediatrician or you about the diagnosis of ADHD, and what that, I guess I'll frame it a little bit. We like to have a home plan, a school plan, and then a medication plan is what we would recommend. And so working with the pediatrician to learn about medication and see if that's a good fit.
Yeah, and you can be as brief as you want with the ADHD, and say you notice some attention, and punch it over to me, because we're going to address that at the end too. So if you're like, this is just a lot,
okay,
just punch it over to me and I can take care of that.
Okay, that sounds good.
Anything else from your standpoint? Do you think that, will you go over, I can explain why, make it very clear why we ultimately decided no autism, but I don't know if in your report you kind of heavily emphasize that, but since that was something that mom seems to keep bringing up. Is that something?
Yeah, I can go through that. There are a couple places in the report where we talk about that specifically, so I can make sure that we highlight that for her.
Okay, I'll re-emphasize it later. I don't want to beat a dead horse, but yeah, I can re-emphasize it later too. But okay. So going back and then OT, I think really quick, because we didn't talk about whether we think, if you're available, it could be helpful to have you there. I think just as many people as can be there to share there, I think.
Yeah, I'm more than happy to be there as support, and then I can come in and share my little blurb too if you need me to.
Sounds good. And then physical therapy. Moving back.
So I sent my stuff to Kate. Were you able to get that into the document, Kate?
I popped some of it right here, and I can get the rest. Sorry, the formatting's weird.
Oh, no, you're fine. When I copied and pasted it over, I think that's what it made it weird in the chat. But I'm happy to be there unless it's like too overwhelming. I can do whatever's most helpful. But the big emphasis is that I think that he could benefit from PT services, but I'm only recommending a once a month status at this time, because I think that will lead to more just improving working on things at the home, and we can adjust his home exercise program. Later on, he might benefit from a weekly standpoint, but I think that is not the highest concern. But I'm happy to go in and kind of talk about, kind of reiterate with the strength and balance and how that might be affecting his walking ability, and how we can kind of first initiate some strengthening interventions. And then if that doesn't work, we can consider orthotics. So I'm happy to come or not come, whatever is most helpful.
I'm always a fan of having more people, but I don't know, Marta, do you have a preference? Do you think this parent would respond better to more people, less people, medium amount of people?
I would probably say less people might be helpful, and having a way for mom's my charting. So like she's reading the my chart. So if mom has specific questions about any of the reports, or after, like Abby, after you explain them, if you feel like mom still felt like, well, that Kim lady still didn't hear me, having a way for them to connect, that might be easier for mom.
Sure.
And like, if you want to be on the Zoom, the teachers will be on Zoom. So if you want to be on Zoom and you know that, and can pipe in like, oh, this is what I meant by that, if it felt natural and comfortable, that's an option. I do worry with how, I don't know, it could go both ways. I mean, she was yelling and cursing at Shannon last week.
Yeah.
So I don't know. Like sometimes if we have a crowd, we behave differently, and maybe, but then she might also kind of shut down. There's enough of us already. I kind of worry about adding more people.
So I guess we can keep a small group.
I kind of like the idea of having people available virtually though, in case there is a specific question, and then you can just answer it. So we have a little benefit to this weird hybrid thing that we can do. So if you guys can be available virtually, and then Abby, if you feel like, you know, that'd be a great question for Kim, then you can just kind of direct them to the screen.
Just to oh, sorry.
Go ahead, Kim.
Would you mean that we would actually stay in the Zoom call the entire time with just our cameras off? Or would it be stressful to mom to see that there are other names coming up on the participants? I just wanted logistically wise.
I think camera off is good. That's what we did last semester, and it worked, and we called people in as needed, and it's worked pretty well. And I think that would be a little less stressful than lots of faces.
That sounds good. So Kim and Kelly will have you virtually on consults for us as needed for questions. That sounds good. And I'll try and kind of walk through your guys' reports, and then just if she has any additional questions, I'll punt it to you guys. So I'll go over your general recommendations, and then as needed, I'll just be like, that would be a great question for Kim or Kelly. Or, you know, so
I just want to say in there real quick that during our interview, any recommendations she wants, if you want her to start a treatment or something like that, she wanted how to start it. And if option 1 doesn't work, I want option 2. If option 2 doesn't work, what's my option 3? She wanted it written down step by step on how to implement whatever you suggest.
Okay.
Because she did say she has ADHD herself.
Okay.
If you need something written step by step to follow, and also if it's a recommendation for school, she wants that written out so she can explain to school exactly what needs to be done.
Okay.
Thanks, Donna. Abby, I wonder if it would make sense to kind of put together a bullet pointed, not overwhelming, bullet pointed AVS as like a mock AVS that you can addend as you go, and you can just ask for input from some of the other disciplines if you need it.
Okay, yeah, I can make a Word document maybe, and then share it maybe under this meeting within Canvas. That would work. And then everyone can, I don't know how to make it editable living document, as we've been calling it.
If
It's a great question.
If you upload the Word document to Canvas, it's not totally livable. You have to download it. I have to make changes to it, and you go back, and then I upload the newest one. Or people can reply to you. Like you can hit the reply button in Canvas, and then they could reply I am emailing you right now.
Okay.
I'm sending you
Okay.
an email of the options for the behavior therapy and the options for OTPT and speech. So she
Okay.
can have 2 to 3 options of each thing. That's all I got.
Okay.
So you can have those ready. But it's not truly a living document like a Google Doc. It's not that living where we can all be in there together.
I realized
documenting.
that with this. Yeah.
So we have
Yeah.
to like save it, upload the updated one, or hit reply, and then you just copy and paste things in at the end. However,
Okay, so I'll put something on Canvas, and then how about people email me? When I post it, I'll put my email so that you guys can send it me email directions on what you think, if things need to be updated. It's gonna be a lengthy document regardless, but I'll try and keep titles and like make it very condensed. That's good feedback, Donna, because our documentation is not always that easy to read. So I'll post something on Canvas, maybe in the next, I'll give myself, maybe by like Thursday, I'll have something uploaded, and then we can see kind of what we think. And you guys can send me emails for what needs to be changed or what needs to be added or what's confusing. Yeah, and Donna, just let me know if when you're reading through it you're like, this is not clear. We're using too much medical lingo or whatever. So does that sound good?
Yeah, that's just what she said in the parent interview. And then is it just going to be a ADHD diagnosis, or are you going with the anxiety also?
Yeah, so I mean, I hear the adjustment disorder. The only thing that's difficult with adjustment disorder is the time frame on it. And I'm not sure I'm hearing a clear time thing. And that is so important for me with the adjustment disorder. And that's like a particular thing for me. But I was going to go with unspecified anxiety. I know that's not great, but I want to see kind of what you guys think, just because I was seeing signs of separation anxiety. However, we weren't seeing it in every setting. So that does make it a little bit less that we're meeting criteria across the board. I think, go ahead. Go ahead.
I don't think her other concern was his outbursts and keeping them under control and stuff like that. So I know we talked about a couple weeks ago about file folders. If that would be something he would.
I don't remember that.
I think somebody had an example of them.
Raisha
has
be direct match to match. So if there's like a
Right.
file folder, the apple, and then you have a picture of an apple and you match it onto there, it's kind of like a calming strategy to help
Right,
kids
so
regulate.
I think he likes superheroes or something. I don't know if that would be something that would work for him, or even to suggest that to school.
Okay. Let me see if I can find some examples. I don't know. Psychology, do you guys have?
Megan?
Dr. Mays, Megan, anyone? Does anyone have a
I
graphic?
think there's a website, so I
Okay.
can put it in the chat.
Yeah, throw it in the chat and I can try and see if we can get some of that.
We do have some examples in DDBP, like on the therapy side, if you wanted to grab one to bring in, but I don't know if anybody has done any with him. I don't know. We didn't do any, so I don't know how he would do with them.
I don't think anybody did any with him, but it's just like, if that would be something that would be calming for him to remove him from whatever's going on and say, let's work on a file folder, or get him interested in something else that interests him. I don't know.
And it just corrects me because I'm not as familiar with this. Is this something that would be like you'd be assisted by a therapist, psychologist, someone
parent
to put this together? Can parents do it on their own? I guess that's my
I don't know if this mom would do it or not. I'm not 100% sure. I can reach out to Raisha because I know she does them with her daughter. I don't know where she got hers from, but I can reach out to Raisha and ask her.
Okay. Yeah.
A lot of the times in our clinic, we kind of pre-make them for the parents, and then they're able to do it at home. So.
Okay. Would that be something that they help to make in behavior therapy? Like if they were to get involved with a behavior therapy, could that be something that they incorporate within?
Yes.
Yeah.
Or even a recommendation we can make for the school? Because I'll provide mom with some examples, but we may need some guidance on that. Okay.
Correct.
Okay, that's a good thing to think about. So overall diagnoses that I have ADHD, combined presentation. I don't know how you guys feel about unspecified anxiety. We can hold off on it and watch longer, or we can make the diagnosis. But that is what I would lean towards.
Is there going to be a medicine for that also? Or is it just going to be for the ADHD?
The medicine
I was going to ask you.
The medicine that I'm going to recommend is something that will help with sleeping difficulties, which is a non-specific diagnosis, which I can list also on their list, but they is going to be clonidine. So clonidine 0.05 milligrams nightly to start. And I am going to reach out to the pediatrician and keep saying I'm going to do it. I'm going to reach out to the pediatrician and see if maybe, because we are so far away, if what the pediatrician is comfortable with prescribing, like if they would maybe be comfortable. If mom is very interested, I can start the clonidine, like I can prescribe it at our ISS and PCP can carry it forward. But I'd like to have a discussion beforehand with the PCP to see, because those are kind of our two options. If mom would like to think about it, the other option is to talk with the pediatrician too and have them prescribe it going forward. But the clonidine is for both sleep difficulties, but we also use it for treatment of ADHD. It's not my most effective medication for ADHD, but he is young and that's what I would, and I think sleep is contributing to behavior.
Yeah, I get that. That's perfect. I didn't know if you're going to do anything for the unspecified anxiety also.
No, I don't think I would, because typically at his age, I probably would start with kind of behavioral interventions anyways, and consistency like across routines and settings. I probably would not personally at his age, especially because I don't think that's his biggest impairment. Like I do think it's there, but I don't think it's the biggest thing that's impairing his day-to-day life. Yeah, go ahead, Kate. Sorry.
Oh, I was just going to say PCIT is evidence-based for treating anxiety too.
Yeah, perfect. So yeah, so I think I would start with that, but I do think it's important to mention maybe because it's keeps coming up. And I think it's maybe our best chance at capturing kind of his adverse childhood, like just the changes he's had to go through in his life is maybe the way I'll phrase it rather than keep saying the word trauma. Like all of the adjustments he's had to make with being in school and, he was with his grandparents a lot before and now they're not there as much. And so that's probably what I would emphasize is that the anxiety is also related to those big changes that he's had.
And mom just went back to work too.
Another big change.
She's gone. Yeah.
Yeah. So I do think it's important maybe to mention it because again, mom is saying we're not getting the whole picture and maybe she's right. Like maybe we need to consider that. So everyone's okay with the unspecified anxiety. I don't like that it's unspecified, but
he's just little.
I know. And we'll see. And that is the thing is, as he grows and develops, he will.
My only question, Abby, I don't disagree with it based on our observations, but just looking at his chart, I mean, she reported to us like no concerns with anxiety. And I heard Lindsay say the same thing. So if she pushes back on where is this coming from, if she's not reporting it, do you feel like you have the evidence to use that diagnosis?
Yeah, I mean, I think I do based on multiple, like what we've reported. And like his association with her in bedtime, his difficulty transitioning from her and other spaces. I think if I bring that up, I might have a chance of kind of convincing her that I think that there is some anxiety component to it, but I don't know. Dr. Williams-Aria, what you think?
Yeah, she may be accepting, and I think he does have anxiety, but I'm just setting you up for she may push back on that, considering that she didn't endorse anxiety in any of the
and I think to emphasize in little kids, it can be difficult to see signs of anxiety, and they often express it in different ways. So some of that does come out in behavior. Some of that comes out in our reactions to things that are kind of disproportionate to what causes the behavior, and then also difficulty with, getting away from mom and, like
Yeah.
going to bed at night. All of those that can look different in very young kids. Anxiety does. So I think maybe if I explain it that way, she may have a better understanding. We'll see.
That sounds good. Sounds good to me.
Yeah. Other diagnoses that people want me to bring up. So we have ADHD, unspecified anxiety. I'm sure there's something for PT. Was there a specific diagnosis?
Yeah, I'm just pulling it up real quick, Abby. So I provided a diagnosis of gait abnormality, balance problem, muscle weakness, and lack of coordination. And I'll send these in the chat. I don't know if all of them need to be included or not. But because I guess, so those diagnoses are already included in my evaluation. I guess my question is, when you're providing the diagnoses, what I'm not sure how to phrase this, like what change, like how does it change like your report? Like, do you need all of them? Do you need some of them? Do you need none of them, I guess is my question.
Well, I want some of them because I think that'll inform our PT recommendation.
Yeah.
I think gait abnormality is important, right? Because we have asymmetry of our gait.
Yeah. I would probably do muscle. Well, I think they're all important. If it's not too much, I think I would include all 4.
Yeah, that's fine. So muscle weakness, you'll put them in the chat. I'll get them from the chat. We'll go from there. And then I don't know, occupational therapy for Kelly. Is there...
Yeah, I put mine in. Kate, I think, copied them. And then I have the numbers next to them as well. I did decreased EDL, sensory, fine motor, and behavior concern were my 4. Again, I don't know how important it is to put all of them, but those are what we used.
Kim, I just had a quick question. Do you think in terms of strengthening, if he gets further along the road with behavioral management and he's participating better, that more frequent PT might be indicated or possible?
Yeah. If he is able to participate better, and I know travel is also kind of a challenge and barrier for him. If we were able to figure out a way around that, I think that it would be very appropriate. I think that he would do really well. I will say, like, one of his strengths, the first hour of the session before he started getting tired, he was very excited to play. He really wanted to please. And he really loved to move. And I think if he develops the right relationship with the right therapist, that we really could make some wonderful progress. I just know that there's other bigger concerns at the time, but maybe in the future that could be helpful, and I can include that in my blurb.
And Kelly, not to interrupt your piece, because your stuff is really important. Is he getting PT and OT at Head Start or just the speech?
Speech.
Yeah, so wondering if that's a possibility, and or having him tested when he goes to kindergarten, if you guys think he might qualify for services in the school.
I think
I definitely think he would benefit from OT in the school, but I agree with like Jamie saying outpatient would be important as well, just with his bathing, dressing, and outside of the fine motor skills.
I think too, just to add to that, Kelly, like I think mom reported a lot of the crashing and a lot of the sensory concerns. That would be great to provide mom with some home program like strategies and things that she can use for that.
I also wanted to add, from like a speech standpoint, we know that he's already receiving services, but I think it is important to incorporate a language goal to his existing IEP, because I looked at it a while ago and I think he was only doing Arctic at school. So I think it would be important for him to have, hold on, I'm gonna pull up his note. To maybe have like some receptive language goals, like following 2-step directions, understanding like concepts such as on off, top bottom, small big, and I can put these in the chat for you, Abby, or email it to you. But yeah, just so we know, like as a group, like that's what I'm thinking. And also like we know that those will have an academic impact on him. So like that would also be a reason why services would be justified when he continues on past Head Start.
Okay, yeah, that would be great. And then from your standpoint, Maria, in terms of diagnoses for him.
So we had written mixed receptive expressive
Mm-hmm.
and then speech sound disorder.
Perfect. Yeah. That's perfect. Speech sound. Okay. Who else do we need? Speech, hearing, we decided nothing. Genetics. Anything else from your standpoint in psychology, Kate? No. Okay.
I just had a quick question with the PCIT. Is there one in Kentucky that they can use? Because I know they can't access children's, correct? So just being mindful of putting that recommendation if they're unable to access it.
Marta did an awesome job at finding us some specific places that they can go.
They
for
don't offer
behavior
PCIT
therapy.
though.
And then we have a website where they could find certified providers, but I don't know like who's doing telemedicine and if they would take their insurance, but if they want to go that route, there's a way to do it.
Awesome.
That's a good point. Other things, so we have a few diagnoses now on here to go over. And then I'll add my little sleep difficulties, which are on there already. Yeah.
Sorry, I didn't realize this was down here, or I would have scrolled down here earlier. But I think, yeah, based on some of the things people sent today, we can update this.
Yeah. Okay. Sounds good. And then I'm going to talk from my standpoint, review the ADHD home plan, school plan. And then I'm going to talk about the sleep difficulties and clonidine from my standpoint. And then otherwise, I think that's what I have. And then for follow-up from me, it's up to, I have to talk to the PCP about their comfort of, because that would determine how often they follow up with me. If I'm prescribing medications, we do see them pretty often. So like, for example, if I'm starting a new medication, I would see them in a month or two after I start it, which is difficult for them, I realize. So I'm really hoping their PCP is able to do the refills on that medication. But otherwise, from my standpoint, he probably could follow with his PCP going forward, but they can continue to see me. But I would probably recommend like every 6 months as needed if I'm not prescribing medications. But I don't know, Dr. Williams-Aria, what you think of that. And I don't know for anyone else. You guys we're not really doing follow-ups, I guess, for anyone else. But
I think that makes sense. We'll talk with mom about, what works for her, and hopefully we can see if the PCP is able to provide any ADHD medication management. But I think at least touching base with us a couple of times to see how things are going would be helpful. And I think 6 months makes sense. Unless we're prescribing medications, then obviously it'll be more often than that.
okay. And then anything from a family perspective that we should be thinking about when we deliver this news? Any tips, tricks?
The only thing I can think of is just breaking it down as simple as possible. Like I said, mom wants everything bullet points.
Okay.
I don't know what other questions she might have. Molly, do you?
She may ask if there's an ADHD diagnosis, if she's thinking of it at the moment, she may ask about ADHD medication because that's something she mentioned to us.
Oh, that's
Okay.
right, she did.
I can talk about the other options when I talk about clonidine briefly.
So
kind
she
of-
may, yeah, she may, that may be something. I know sometimes with parents, we're always we always wonder, where does this parent stand on medication? And she was crystal clear with us that she was open to anything, including medication management.
Okay. Then I will bring up the other options too and explain why I'm thinking clonidine, but open to hearing kind of what mom's thoughts are. But I'll bring up the other options of the PCP too, to see kind of their comfort. I mean, this child is young and most PCPs don't like to, most PCPs will give them to developmental peds if we're going to do a stimulant medication. But, which I'm fine with doing. I just think the clonidine will help with sleep. Good to know though. Other thoughts? Keep us in your thoughts.
Just that Abby, you did a really nice job coordinating this meeting.
Thank you.
Really beautiful, beautifully done. Great job, team. Fantastic.